your assigned brain at 5 o'clock is the thoracic duct. At 6 o'clock you have the spine. At 7 you have the aorta. At 9 you have the vagus is somewhere here. So this is the anatomy we should know. So this is the spine. So you have two approaches of doing the poem. One is the posterior approach, the other is the anterior. So for anterior approach, this is 12 o'clock. We make incision somewhere between 12 to 2. For posterior approach, we make incision somewhere between 4 to 5. So this incision in the mucosa will allow us to enter into the submucosal tunnel. Once we enter the tunnel, we are going to dissect and reach the tibia and go to centimeter and then come back and then start doing the myotomy to release the spine. So that's the idea. So as I mentioned, 4 steps. The first is making incision, second tunnel, third myotomy, fourth closure. So I will do the first step. So the first step is making
sitting there. So one second.
Yes, sir.
We'll put a mic so that people are watching outside.
Oh, is it, sir?
Yeah.
Oh, is it?
Live relay is there.
No.
They manage it. Oh, is it?
Department.
Great, sir. इसको निकालना पड़ेगा. Yeah, I think we need an access, na? Yeah, this has to be kept, I believe. Yeah. So now, sir, to make the incision, the next important thing that we have to understand is what are the current settings that we are going to use. So, in order to make an incision, I am going to use the endocut that we use for our regular reactive sphincterotomy. For doing the submucosal tunneling, I will use the coagulation, either the post coag or the precise if you have the biopsy. And then again, finally, the myotomy, I will use using the endocut. So, very basic energy settings. So now I again reassign, relocate my position. So wherever the water is gravitating, that is 6 o'clock. So I will make an incision somewhere at 4 to 5. So what I am doing is that I am bringing out my knife. Here is my knife. So my knife comes out. I am going to make a gentle small opening there. Yeah. Yeah. Inject. Inject. 1 second. 1 second. Yeah. Inject. So now that's the first step, sir. We are going to make a nice bleb there. So once you have the bleb, enough. So now the point time to make a incision. So now once I made my first incision, I am going to gently open up and see where I am. So we are injecting the methylinated water, NS. So that will give a bluish hue to the submucosa. Inject. Yeah. So as soon as I make my first cut, I make sure that I can see that bluish thing. Here you can see the, I'll make one more cut that will make it easy for you to understand. Yeah. So I think now you can see that bluish thing which I was talking about. Yeah. So the one that is burnt out is the mucosa. What you are seeing is the pearly white here is the muscular is mucosa. Then this is the submucosa. And beyond this is our muscle. So now I made a decent cut here which I feel is good enough to allow my cap to enter. Now we have to understand that this is a vertical slit and you have a cylindrical object that needs to enter. Since you cannot directly enter into this, so what I do is that I am going to ledge on either side to create a cavity so that my scope enters. So the first thing I am going to do is go to the apex, inject. Now I used endocut, now I am going to use a precise or forced. You can see that I am slowly trying to understand where is the muscle. See, I am gently clearing the submucosa. Yeah. So in ESD, we work in the upper 1/3 plane. Whereas in poem, sir, we work closer to the muscle because we want to make sure that nothing happens to your mucosa. So you can see a pearly white thing there, that's the muscle. That's the muscle. So what I'm doing is that I'm gently clearing this entire area. Yeah. Yeah. So first clear the apex. Then once the apex is clear, I will go to the right side. You can see the muscle there. Then I will clear on my left side. Inject. So once I have done enough, I'll just take it the incision to 12 o'clock and then make a gentle end. So we are into the tunnel. So we have entered the tunnel, sir. So once I have entered the tunnel, I will make sure that my muscle is on the right side, the mucosa is on the left side. So this understanding makes the job easy because my technician also knows that the muscle is on the right. Any inadvertent injury on the muscle is never a problem, but mucosa has to be protected at any cost. So now once you are in, we catch the shaft and keep the small wheel right, and there we start. Now it's all about advance. Now you leave it, Amma. I will take care. So I am clearing more towards the muscle side. So you can see that small thermal injury on the muscle. So push the scope in, bring it out, take the big wheel down, knife out, keep the knife steady, use the shaft. With the shaft along the muscle, you keep cutting. Done. Again, advance the scope. Advance. So when in doubt, all you need to do is inject, inject, inject. So I think the key point in learning a poem is that keep the shaft, use the shaft, never touch the needle too much. Just use your shaft. And keep advancing. So now I am not seeing anything clear. So what I do is that inject. When in doubt, inject. So injection will make that potential submucosal space to appear, and again you can see me doing it. Again, advance, precise, inject. So when you have these vessels, sir, if the caliber of the vessel is less than that of the shaft of the knife, you can use the knife itself. If the caliber is big, we change to quack. Yeah, inject. So I'm at any point I'm making sure that my knife is facing the muscle, never the mucosa. I always make sure that the mucosa is safe. So now you see, sir, this is our transition point. We noted that endoscopically our G junction was at 40. Now we have reached the 40. So this is the LES. So how to know that you have crossed and entered the gastric side for sure? There are 6 ways of knowing it, sir. The first one is endoscopic measurement 40, which is corresponding to what we recorded on endoluminal side. So that's exactly here. The second is that gastric side arrival is marked by the arrival of these comma-shaped blood vessels. Comma-shaped. You will see numerous palisade comma-shaped vessels. These indicate the arrival of the gastric end. So point 2. Then the point 3 is you come out of the scope, do a retroflexion, you will see a nice bulge, bluish bulge on the fundic side. That also indicates that you have crossed onto the other side. Then the other fourth way of doing it is that take a pediatric scope, put the pediatric scope in the tunnel and an adult scope in the gastric side, still you can make it out. So there are a couple of ways of understanding whether you have crossed it. What we use in our routine practice is G junction, anatomical landmark and the comma shape vessels. The moment I see these comma shape vessels, I am sure we are on the gastric side. So from here I will do a 2 centimeter dissection to the gastric side. Inject, inject. So the common thing that's probably put against a poem procedure is that we don't do any fundoplication. So incidence of reflux is something that's always put as a question mark to us. So what we do now, we have learned is that we have started not doing an aggressive gastric myotomy, not more than 2 centimeters.
How do we know that we are going towards?
How do you know? That's a very good question, Dr. Aradhya. So what we do is that when you are doing posterior approach, what is on the right is the lesser curve. What is on the left? So when you are doing it on the right side of the spine, you are more or less directed towards the lesser curve. When you are on the other side of the spine, that's when you will enter the greater curvature. So now you see I am entered the gastric and inject. Yeah. I hope ma'am it's okay on the EtCO2. Yeah. So one trick of maintaining the EtCO2 is that, sir, we take the finger off. When you are doing a regular endoscopy, we put this finger for constant air, but we take it off. So only when needed. And second is that the tunnel should be at least 1.5 times the scope diameter. When the patient will be gurgling out the CO2, it won't enter the adventitia so easily. Inject please. So now we are, can you please remove? Now we are just passing the 40 mark, sir. So I will do another 1 centimeter on the gastric side. I'm sure you all can appreciate that comma shape vessels, sir. Numerous. See, these are all that comma shape. So they indicate that you are on the gastric side. They are never there on the esophageal end. So you can see them more numerous, sir, here. See here. Now we are 42, sir. So this is what we wanted to do, not more than 2 centimeter on the gastric end. Inject please. Inject. Yeah. So now that I am satisfied with that 42 mark, what I'll do is that now third measurement, sir, come out and check on the endoscopic side. So when I have come out of the tunnel, I will check how good was my mucosal integrity. Did my thermal injury occur anywhere? So here I see it's good. It's good. I reach the G junction. I go in. I do a retroflexion to look for that bluish blood. So I hope you can see a soft swelling here, sir. So that swelling is my injected on the other end. So that's why you have got that soft indentation here, the bluish. So once again, we will just check again whether we are correct anatomically, sir. So when I am coming out, I take out the entire air so that my anesthetist is comfortable. I check the abdomen, no capnoperitoneum, no capnothorax. So now again G junction corresponding to 40. So we will do a gastric myotomy up to 42 and from 34 to 46 centimeter of esophageal myotomy. So second step is over, sir. Now we will enter the myotomy zone. So again enter in, get to your position, bring the knife out. Now to do myotomy, sir, the choice is yours. You can use endocut, you can use force squat, or you can use the precise. The choice is yours all along. So this is the muscle plane, sir, we wanted to go. Yeah. Catch it like this. So we wanted to start it at 34. We are going to start at 34. Yeah. 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 So this is somewhere here. I am going to start the myotomy. So initial, I am going to take 1 or 2 delicate cuts to understand. No, I am using endocut initially to separate and understand what is the muscle plane. See, these are all the circular fibers. So I need to go little down. So now you can probably understand them better, sir. So these are all the longitudinal fibers. These are the circular fibers. So I will try to dissect along the intermuscular plane. This is the plane I will do. I'll keep my knife steady and then I'll just keep cutting. So I think sir, probably sir will agree with me. Now this is the myotomy, sir, which we are doing. So you can now gently see the circular and the longitudinal, sir. Both the muscles are visible. So I am trying to run in the intermuscle plane only, sir. So as I am approaching G junction, sir, I will try to go slightly to the right side because as per the anatomy, on the right side you have the clasp fibers, on the left you have the oblique fiber. So I want to spare as many oblique as possible because oblique are responsible for maintaining the LES and prevent reflux. So I am just gently going to turn a little onto my right so that way I can prevent or save couple of clasp fibers. So I have reached the end of my tunnel. So this is at, can you move your hand? Amma? So this is at 42, sir. 42 where we wanted. So G junction is as 40, we are at 42 and that's quite good enough for her, sir. That should handle her problem. My item is done, sir. Yeah, yeah, yeah. So we started with the, I mean, what the guideline says that when you are doing start partial myotomy, but as soon as you reach the G junction, you do the total myotomy. So that's what I did here. We have couple of fibers here, yeah, which we can take out. That's it, sir. So this is probably the lesser sac we are talking about. No, no, we are now very much into the gastric side now. So this is lesser sac. So that's it, sir. So this is your total myotomy on this side. Ah, sir. So we had our V junction at 40. So we went up to 42, sir. 42 on the gastric side. So 2 centimeter of gastric myotomy and this is the G junction. Because we wanted 6 centimeter esophageal myotomy, I did my myotomy from 34. Because I made an incision from 32. So I added 2 centimeter gap. So I think that completes the procedure. Now we do the important part, closure.
How did you see the end of the 20 coagulation?
Yeah, sir. After some time, you'll also be like that only, sir. Don't worry. Clip, any clip. Yeah, any clip. Metronic, whatever, whatever you. Yeah. Which one, sir? Huh? No need to do. Partial is good enough. Sir, sir, the trick you asked, sir, that's the trick, sir. When you are running in the intermuscular plane, the risk of bleeding is less. If you do total, you end up cutting the vessel on the beneath side. Close, close. Open. Close them gently. One trial. Yeah. Clip it. Yeah, done. Yeah, whatever. I need 2 more. I can close it in 2 more. Whatever you give me. Whatever you give. Is okay now, madam? Is okay, sir. Close, sir. Open, please. Rotate. Slowly, one on one. Wait. So these are the clips, sir. This is how we close. We can suture it also, sir. No, wait. The left is not hooking up. Yes, 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 Aradhya. We have to see both the hands and make sure both of them come in line. Actually, I can close it with one. Now. Clip it. Wait. You, yeah, open. So when I say clip it fast. It'll slip. Catch like this. No, thank you. Ah, wait. Now try to bring them together. Close it. Clip. Done. One last clip. Any clip. Sorry. Any clip is fine. Close. Acha, this is Olympus, na? With the no problem. You have to take it inside, na? Close. Close. You're okay with the okay, sir? So all luxury to me only. You guys don't want. Santosh doesn't want that to happen. No, but I. No, wait. Sir. Yes, sir. It depends on the current. I think it should be going side, no? Enough, huh? So yes, sir, it happened. Close. Open. So now the last clip, sir. Yeah. Catch your scope. Yeah. Wait. Close. Clip. Done. Done. Thank you, sir. Thank you.
Open elders.
Sir.
Old cases of two of us, me and the destination that we love. That is open elders. It is done beautifully. It is about 90s.
Right, sir. Sir.
Afterwards, of course, we get but this is wonderful.
Keep the scope almost parallel to the patient, sir. Trace one radical. This is the radical of the portal radical. What you are seeing is the left lobe. So pull back, keep the radical in center. Now what I am imagining, I am not doing much, sir. All I am seeing is that I will show you with our, no, this one, note, comment, yeah. So this is the left lobe, sir, and what you are seeing here is the left hepatic vein. I'm going to get the keyboard. Yeah. No, the left hepatic vein. This is left hepatic vein. This is segment 2. This is segment 3. Now, catch this radical, sir. This is portal radical 2. So, this is step 1. Now, once you have the portal radical, keep it at 6 o'clock and now just turn clockwise. You see the left hepatic vein, portal radical, just raise your left hand, sir. Left hand, the left portal radical will join the P3. There it comes, sir. There it is. Now they are joined, now there. Did you see that, sir? What was coming from top, P2, this is P3. Segment 3, portal radical, segment 2 will join. So that is the next step. See, this is called fisheye. This is the fisheye, sir. So what here you are seeing is that add. So we started with P2 radical, you reach the fisheye, this is the umbilicated portal vein. If you see umbilicated portal vein, this is segment 3, this is segment 4, and what you are seeing white thing is the ligament, sir. On the top right is ligamentum venosum, on the bottom is the ligamentum teres. Now this is step 2. Now once you get the fisheye, then you turn further clockwise. Now all you get is that what you are seeing there is the left portal vein. That is left portal vein. Now if you follow the further turn clockwise, the left portal vein will lead you to the hilum. So that's the hilum now. There you can see the hilum, sir. I will tell you the parts also now. Yeah. Okay. Yeah. So now here, and so we were chasing this guy. So that is the left portal vein giving rise to main portal vein, and below main portal vein the anechoic structure that is running parallel is the CBD bar CHD, and below that you have one more globular structure that is the gallbladder. And if you are very careful, sir, between CBD and main portal vein you will see one more structure, that is proper hepatic artery. That is proper hepatic artery. Now you see, sir, now I have shown you all. See, portal vein, hepatic artery, CBD, this is gallbladder. Now I will take my portal vein, what you are seeing here, sir, yeah, this is the right branch that's going down, sir. This is the main portal vein. So keep the main portal vein in view and push the scope 2 centimeters in. Gently push. I am just following the portal vein, sir. Just follow the portal vein. Just follow the portal vein till it reaches the confluence. See, there is the confluence. So I am following the main portal. Can you freeze it? Please freeze. So I was following this guy, sir. So this was our main portal vein. It has reached confluence. This is confluence. What takes a sudden outward turn is the SMV, and what goes above is the splenic vein, and what is adjacent to splenic vein is the splenic artery. So once you understand this anatomy, sir, what is below SMV and main portal vein will be the head of pancreas. This is HOP. What is very close to the SMV is the genu, and what is beyond splenic vein is the body of pancreas. So we have to understand this structure, sir. Once you get this picture, then you know what is the thing that you are looking at. So I will take that out, sir. See again. So followed the portal vein to the confluence. There is a confluence. This is the CBD I am following, sir. You can put a Doppler if you want. You can get a. We'll take out the cursor. Yeah. So you can see there, sir. I followed portal vein right up to the confluence. This is the SMV, and here you can see the CBD right below it. Yeah, this is the CBD. Now from the other end you are seeing one more structure coming, sir. That is anechoic, where the cursor is there. That is the MPD. That's the main pancreatic duct. This one. This is CBD. This is MPD. So both are not picking up the color for that reason. See.
Yeah.
So both don't take the color. So this is the proper head of pancreas. Aradha, can you freeze if you don't mind? Yeah. So this is the head of the pancreas, CBD, this is SMV, and this is your MPD coming down. So now we can take it down and then we go, sir. Now we again come back to confluence. See, I am bringing the portal vein confluence. Yeah, this one. The one that is where exactly is the cursor is the portal vein confluence, sir. So I turn clockwise. And what you are seeing, two structures colored are the splenic vein and artery. The one that is distal and bigger is the vein, that is one closer is the artery. And above between the probe and the artery, what you are seeing is the body of pancreas. So once you get that, see sir, now that's the MPD sir on the top. You just, we will take out the color. Yeah, we'll take out the color. So keep that splenic vein in the center and turn clockwise. You got the left kidney, sir. The one on the bottom. See, here this is the left kidney. If you turn further clockwise, keeping the splenic vein in center, you get the splenic spleen, and that's the splenic hilum. That's the splenic vein entering the splenic hilum. So my comment is that, sir, when it came to spleen, there is no pancreas, only spleen and gastric mucosa. This gastric mucosa, I mean stomach, gastric mucosa, spleen. That means patient has got atrophied pancreas. There is nothing here left. No pancreas here. So we go back. Head, lot of heterogeneity is there in the head, sir. Yeah. You can see a collection also here. But I think here, this one, where the cursor is there. You can actually see the MPD with a sludge ball inside, sir. That's the MPD with the sludge ball within it. Yeah. Stone, because it is not casting acoustic shadow, I feel it's a soft stone. It might be only soft stone, sir. Yeah, you can see very nicely, sir. See. That's the soft stone within. That's the reason MPD is dilated, sir. Maybe I'll check with her if I can get into the D1. Yeah, I got into the D1. So when I reach D1, sir, my point is trying to get the home base structure, that is the portal vein. So I will try to look out for portal vein. Yeah. Here is the portal vein, sir. Yeah. Aditya, can if you can put a color if you don't mind. Yeah. So color I am using only to make it easier. We will take out the cursor. Yeah. So the idea is to get this guy, sir. I am showing you that guy. Yeah. This guy. Now, I want you to freeze it somewhere. No. Yeah. Wait a second. Yeah. Roll it. Scroll it. Actually, your where is your CG? कितना है? ज़्यादा है. It's the color is spilling out. You need to go down on the gain. Gain कम करेंगे, the color will come down. No. Gain of the contrast, not the gain of the this one. The color is spilling, sir. That's because the gain is high for the. Now you freeze it, Aradhya. Freeze it? Yeah. Yeah. We'll take out the color. Maybe color is. Yeah. Yeah. We'll take out the color. Yeah. Yeah, sir. That's what I am just trying to show you the portal. Now, yeah, I will freeze it here. Yeah, I will freeze it somewhere. Freeze it, please. Yeah. Sir, this is the main portal vein, sir. So why you need to understand this is that this is the home base structure. So once you get the main portal vein, this is the confluence. Now D1 imaging is mirror image of G junction. So what is close to the probe in G junction will be away. Like your splenic vein was close on G junction. Now it will be away. So this is splenic vein. This is your SMV, sir. Then this becomes the HOP. If that is HOP, any part of the pancreas beyond this is the body. And what you are seeing on this side will be the right lobe of liver, sir. The right lobe will be on this side. Now I will demonstrate all the three things, sir. So first catch this one, yeah. Now portal vein, this is the CBD, sir. This is the head. You can see that the head is inflamed and hypoechoic, sir. So significant head is hypoechoic. You see that the epithelium, the duodenal wall is all edematous. So there is a lot of edema there, sir. So we are trying to go down. There is a lymph node here, sir. So this is head, this is intrapancreatic CBD, and this is your head of pancreas, and this is your MPD, sir. This is the duodenal wall. So now if I want to trace it to the hilum, I have to go slow anti-clockwise, sir, which I am trying to do now. See, this is the liver part coming up on the top. See, the portal vein and the CBD, and I am trying to go to the liver. So this is the liver, and this is the portal vein entering the liver. That's your CBD, CBD, GB, GB and CBD. Sir. So nothing here, but here it's lot of edema is there, Dr. Aradhya. See, this is the collection in the head. I don't know whether you can appreciate now. See, that's a collection, sir, in the head. See, this is a collection, sir. It's a nice collection in the head causing with goo. So it's a collection only. Maybe you should put a this one caliper. Yeah, we'll set it. I think we should take this one out. 3 centimeters on the widest on this side there. Okay. So no, sir. I feel this is more of so this is definitely a collection. Sir. This is collection. See, you can see the content is thick and debris is moving, and this is all edema around it, sir. Yeah, if patient is in goo, maybe either draining it, sir, or putting a NCD and waiting for it to resolve. But this is definitely collection, Dr. Aradhya. I don't think it's a, I am sure you'll all agree. So this is a collection. See, you can see the fluid movement there, yeah. Okay. MPD, yes. Yeah. We were able to see there, na? You were able to see nicely from here. See here from here. See, this is all MPD coming down. And that MPD is dilated because of that collection in the down. See, this is the collection. Now I can show you the collection also from here. See here. Now can you see the dark thing? Yeah. This is the collection. Here, this is the collection. This one. This is the collection that is actually causing, it's a warn, sir, proper warn in the head of the pancreas. If patient is very symptomatic, putting a, then NCD, I mean, you can put a NG and probably wait. Thank you.
Let's demonstrate.
So in that two station, you are going to show all the structure G junction and
Yes, sir.
Then we will go to T2.
Sir, only when there is complete answer.
Yeah. Just slightly on the lower side. Yeah. No, it's totally closed, I think. Sir, one of the fundamental things, sir, when we are doing third space poem, na, sir, make sure you personally put it on standby. Air on standby. This we have to do it, sir, because any air open within 5 minutes, patient will bloat up. So air on standby and CO2 as much low as possible, and then we enter, sir. So once I enter, the first thing I would like to scan is the glucose health, sir. So we will keep, because I am examining, I will keep it. I think it's not on. I think. But this, I think you have put it standby, na? Yeah. Yeah.
Girish is from Stanley.
Sir.
Girish, nice.
Oh, is it, sir? Okay. So, sir, this is little dilated esophagus only, sir. So, long-standing eclasia maybe. So, again, we go in. So, this is, so we always measure in withdrawal, sir, not in when you are pushing the scope in. So, now I am into the stomach side. So, I'll aspirate everything that's in the stomach. I'm sure patient is given one antibiotic shot, sir. Yeah. So, sir, when I am coming out, I am just looking at for the Z line. Yeah, where is the Z line? Yeah. So somewhere here is the Z line, sir. That's the Z line. 8 minutes. Yeah. So it's more or less at 41, sir. 41. 41.
Yeah.
So if it is 41, I will do gastric side myotomy 43. Esophageal side I will do 6 centimeters. So 41 minus 6 is 35. So my tunnel entry will be from 33. That is 2 centimeters proximal to my proposed myotomy. So 33 is where I want to land my scope. So this is grossly dilated, sir. Yeah. So I will start somewhere at 35. Yeah. Santosh, give me a knife. Yeah.
Esophageal side, no? You say some 6, 7 to 8.
Sir, previously we used to do average 8 centimeters, sir. Now the new concept is that type 2 you can do even 5 is good enough. So 5 on the esophageal, 2 on the gastric, 7 is good enough, sir. So what I will do is that,
2
sir.
centimeter above that.
We will maintain a mucosal flap of 2 centimeters above it, sir. So what I am doing here is that, sir, 35, yeah, 35, yeah. So again, sir, if this is the spine, sir, you can see this is my spine. So my approach is, if it is anterior, I will inject here, sir. If it is posterior, I will inject here. Because keeping the spine at 6, this is 5, this is 1 o'clock, assuming this is 12. So this is for anterior approach, this is for posterior approach. Sir, nowadays there is a paper by Dr. Moin Kashaf, sir. They say anterior, posterior, it's your choice. Outcomes are same. Yeah, maybe, sir. That's where you can change that. So what I'm doing now, sir, I'm going to enter now. Inject. Yeah. 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 Enough? Yeah. So now first cut, using the endo cut, I made a cut, sir. I am trying to understand whether I am not deep. If you have made a deep cut, this is the time to abandon the procedure, sir. I am just looking if there is a bluish thing is there or not. Maybe the second cut will make it. Inject, please. Enough. So I am using endo cut, sir. So now you can see, sir, that blue thing. So the bluish thing is reassuring that we are not deep. This is submucosa. So we are in the submucosa, not beyond. So yeah. 3 cuts will open 13 mm, sir. The scope for Elumbo scope 9.5 with cap, it's around 10.5. So if you, this knife is 4.5 mm, sir, foot length. So if you do 3 cuts, it's around 13 mm. So I generally do 3 cuts, then I know I'm good enough. So now once I'm done, I go to the base of it, sir, apex, then use the forced quad, sir, now. So I'm using the forced quad. Yeah. So see, can you see that pearly white, sir? That is the muscle. So I don't want to go deeper than that. So inject, please. Yeah. Yeah, enough. So now you can see the muscles, sir, there. There are circular fibers. So once I see that, that is my end of my ledging on the apex. Now I will go to the left side. So I will clear for the left, sir. Now once I have cleared the left, now I will go to the right, sir. So what I'm basically doing is that I'm making that vertical slit under mine so that it allows me to enter. Now I've done left and right, sir. Now I will turn the incision to the top and then gently try to push the two lips outside and then make a gentle entry. And we are in. So we are in, sir. Now you can see that fibers, those are the muscle fibers. So that means the muscle is on the right, the mucosa is on the left, and what is seen ahead is the submucosa. Inject, please. So now what I will do is that, sir, fix the knife, bend your scope, yeah, precise, huh? Yeah, yeah. So I am working only on the muscular side, sir, not on the mucosal side. Never target the mucosal side. Yeah. See this way, sir. See, always the knife is towards my right side. Because even if I overshoot, I know it's only the muscle that gets sacrificed. Sir, please come, sir. So how to do it, sir? This is the way. First thing is inject. Give full injection. Inject, 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 inject. Yeah. Once you have injected, this is the muscle, sir. This is the muscle and that is the mucosa.
Not get lost.
So how to not get lost is, the simple trick is that two things. One, keep intermittently burning the muscle. So you will know where is the muscle. Second, the muscle fiber should be perpendicular to your scope. That means that your tunnel is straight. If the circular fibers are going in an oblique or at an angle, that means you are actually tunneling in crisscross direction. So that's the funda. Now, yes, sir, we have to use the post or precise, whatever we are planning to use. Advance the scope, sir. Yeah. Yeah, some bleeding must be there. If you can come back and see, sir. Yeah, somewhere it is. Flush, please. Flush, flush. So there is a oozer there, sir. Flush, flush, flush. Take the quad. Sir, you want me to handle that and give it back to you? So what to do when you see them, sir? You can clearly see there is a oozer here. So the first thing I will do is that I will tamponade, sir. I will put my cap there. I will put a cap. I will put my big wheel down. So now everything is stopped. I will take a coag. Need a coag. So sir, whenever you see a bleeder, sir, the first thing you do is use your cap to your advantage. Press your cap, maintain the vision. Do not lose the vision. Now that I have tamponade it, now I will ask my assistant to give me an accessory, preferably a coag. And now, now okay. So now by the time they bring in, sir, I will try to see where is the bleeder in sore. See, it is here. So flush please, flush, flush. So it is bleeding there. There is a small bleeder there, sir. So I know where it is. Now I will use my again cap. Tamponade it. Bring in the coag. So it is right at 6 o'clock, sir. So I already have a mental map of where it is. So I will bring in the coag. I won't leave the cap, sir. I will keep the pressure on. I will adjust my, it's basically what I want. So I will come back gently. There it is, sir. Open, catch. Flush, please, flush. Sir, now we got hold of it, sir. Soft coag. 1, 2, 3, 4, 5. Leave. Done, sir. Close. We just come back, see what's happening. Take the cap pressure, see if it is bleeding further. Flush further. Sorry, it's called. So bleed has stopped. You are good to go. So use the cap, sir. Using cap is important. Precise, precise. Keep precise.
Your in out part.
Advance, sir. Advance the scope. Inject. Yes. Now cut, sir. Use the force. Precise set. Try to play closer to the muscle, sir. In that way, you can always, very nice.
It should not come toward the mucosal side.
Yes, sir. At no point, because thermal injury to the mucosa trouble for us. Yeah.
Inject.
Yeah. When in doubt, give generous injections. Sir. Sir.
How much?
Four you will have it, sir. Usually 3 to 4 mm, sir. Yeah. Yes, sir. Always right wheel to small wheel right, sir. Small wheel right, that will bring you closer to the this one. Yeah. Yes. Yeah. Very nice. Yeah. Keep advancing, sir. Yeah. Very nice. So if you can push the knife slightly outside, that white tip of it should be visible. Yeah. Now better, sir. Or else the cap will take the energy. Yeah. Little slightly longer pause on the blue button, sir. More energy will go. Inject, is the, yeah, yes, sir. Early days, generous injection, generous, sir.
It is to make the things prominent.
Yes, sir. And also that will safeguard the submucosa and the epithelium. Take it out, sir. Continues, yeah. Yeah.
In between, there was one small vessel was there.
Yes, sir.
It got
Yes, sir. That's a precise site effect, sir.
okay.
So you don't need to worry much. Big wheel down, sir. Away from you. Big wheel away from you. Now again, press. Yeah. Yes, sir. Yeah. Small wheel right always. When in doubt, inject, sir. When in doubt, inject. Yes, sir. Slightly knife out, sir. Slightly knife out. Yeah. Good enough, sir. So big wheel down, small wheel right. Always. Sir. Yeah. Good position now. Oh, yeah. Yeah. Maybe she's holding it too tight. Yes, sir. When in doubt, inject your comfort. Inject. Yeah. Advance the scope, sir. Advance the scope. Yeah. Advance the scope. Keep advancing the scope. Yeah. Yeah. Big wheel slightly down, sir. Yeah. Yes. Big wheel down, sir. That the top is mucosa, sir. Probably you are crossing the G junction, sir. Yeah. Yeah. You can inject. Yeah. Yeah. You can manually use your force to get in. Sir, knife out, sir. Slightly knife out. Knife. Yes. No problem, sir. Keep marching, sir. No issues. No, knife in, amma. When sir is moving in and out, knife in. नहीं तो trauma हो जाएगा. Yeah. Sir, go advance the scope, sir. Advance the scope. Advance the scope. Yes. Again, good position, sir. Yeah. Knife out. You're okay. We will go down on this one, sir. If you 42 आ गया. 43. No, it's already clocking 43. 3. That's why it reduced it. Low. Yeah, G junction, sir. That's why. So, delicate. Sir, if in doubt, if not sure, I can clear it, sir. If you are in doubt. Inject generously, sir. Inject generously. Yeah. Yeah. Little bit of slow dissection you will get across, sir. It's not that bad. Yes, sir. Now you are at G junction probably, hence it's too narrow zone. So always play on the muscle side, sir. Yeah, that's the muscle side. Yeah. Yeah. Hit it, sir. Hit it the current. Yeah. Hit it. Pedal, blue, sir, blue. No, no, yeah. Yeah, you can inject again, sir, if you are not certain what is happening there. Yeah, yeah. Now hit again, sir. Hit the blue. Use the current, sir. Yeah, blue. Yeah, hit it, sir. Hit the blue. Yeah, yeah, yeah. Not happening much. Yeah. Oh, maybe do it from. Yeah, yeah, yeah.
You're not using the needle. You should pull back the thing. No?
Yes, sir. Yes, yes. Yeah.
Inject ಮಾಡಿದ್ರೆ
When not in use, we always keep it on the back foot.
needle ವಾಪಸ್ ಹಾಕ್ಬಿಡು.
It's not clear, sir. Maybe see. Yeah, you want me? Yeah. No, what I might do is that. No, this is the G junction, sir. Definitely for sure. So what I'll do here is that inject generously, sir. Inject. Yeah. Now what I'll do is that, sir, I'll cut where I know is the muscle, sir. This is muscle, I know. So this side is the muscle. So I'll only cut on this side, and I'll inject. That will way I can clear my pathway, sir. See, sir. It's only a matter of 1 or 2 centimeters, sir. Inject. So more injection, more on muscle, sir. Sir, slightly longer pause, sir. If you can press, you are pressing little. What can I say? Shorter, slightly, slight longer, sir. 1 more millisecond, you will get more energy. As a inject. I think we are through. Inject. Yeah, we have crossed. Give it back. Not yet seen. Yeah. So they will come, sir. They will come. Only thing we have to watch out is that, yeah, sir. One thing I'll do is that I'll just come out once, check. No, that was a bleed that we had. Yeah, I think that'll be clear now. Yeah. So this was our tunnel, sir. You can see down one, the bluish part. Let me see. Yes. So here is the blue, sir. You can see it going down very nice. So we again turn around and see, sir. Yeah, it's coming. It's just forming, sir. Yeah. You can see one more here dissipation on this side also. So another centimeter we should be quite. Always will deflate the stomach, sir, totally. That will take care of no issues on this side. Then we come out. Yeah. Yeah, I've just slightly increased it. It is okay now. So again, sir, when you want to enter, take it to 12 o'clock, sir, and then gently enter in, and then go. Where is our? Yeah. So, yes, there we are. Now probably you'll see the comma, sir.
Yeah,
Now satisfied.
yeah.
So now you got the comma, but there is a vessel here, sir. There is a big one sitting here on the right side, sir. This one. So out, please. So now you are convinced, na, sir? You see comma, sir? Yeah. Inject, inject. Yeah. So we are also, we wanted to be somewhere here only, sir. Yeah. I'm not touching that vessel, sir. I'll let go. Yeah. I'm not touching it. Now where am I? Say more comma, open your hand. Sir, 41, we wanted to go up to 43. We are very much at 44. So I will not touch that vessel. I'll come back and we can do the myotomy. So you can do the myotomy, sir. I'll just initiate it and give it to you. Yeah. So we will initiate it here, sir. Yeah, sir. Yeah. We will give a little bit of cut with our endocut, sir. Try to understand where are the frames, sir. So I hope you got
Yes, yes, I got it.
longitudinal and those are circular, sir. So we pull back and try to run it. Sir, keep this steady, sir. Don't touch the knife, sir. Keep the shaft, take the shaft, go in, cut, and then raise it. That's it. Only shaft, sir. See, now you got the plane, sir. Here is your plane. Here, sir. You can see the plane, sir.
Yes.
This is the plane. You keep it here and just big wheel up, sir. Big wheel up. Don't touch the knife. Here. Yeah.
When we start doing myotomy from the starting of these, the difference is there.
From the starting of
Incision there on the complete myotomy.
not much. I mean, if you can maintain some gap, that gap will collapse and that will prevent any seepage and trouble. So at least 2 centimeter. Yes, sir. Use the shaft and the big wheel, sir. You can ask your technician to hold it at 6 o'clock in case. Hold it at 6 o'clock. And now knife slightly out, sir. Knife slightly out. Slide out. Yes, sir. Now use the shaft, sir. Enter that intermuscular plane. Big wheel up. Big wheel up. Big wheel up. More up. Yeah. Now cut it, sir. Cut it. Cut it. Advance the scope, sir. Don't retract the scope. Yes. Yes. Again. Again. Same, sir. You can always, yeah, big wheel up, sir, big wheel up. Big wheel up, closer to the muscle, yeah. Some more you can go in, sir, if you want. Yeah. Big wheel up. There's a vessel, sir. There's a vessel, yeah. This is appropriate. Use the blue button, sir. Yeah. Yes. Yeah. Yes. Good enough, sir. Perfect, sir. Avir, you are perfect. Now you are using only the shaft, not touching the knife. Yeah. So there are people who use combinations, sir. They start with blue and then they go back to cutting current. Yeah, because you can see there is a vessel there. See, so if you want to avoid those vessels, always blue. Sir, above, sir, above it. So that's the point of trying to going in the intermuscular plane, sir. That way you will never encounter big vessels. Push the scope, advance the scope, sir. Yeah, big wheel up, big wheel max up. Now you cut, sir. Yes, very nice. If you want, you can clear the lens always, sir. Yeah, absolutely good. Great. Very nice. Yes. Yes. Do it again. Yeah. Use a endo cut one, sir. Yeah, that will take care of that. Yeah. Advance. Yeah. Yes. Sir is a pretty fast learner. He's already doing the shaft. Excellent. He's not moving it. Sir, lens clean, sir. Lens clean. And be careful, sir. Now you are on the gastric side. So play close to the muscle wall. Keep the big wheel up and cut. And use only blue, sir. Post only. Yeah. Now do it, sir. You're doing wonderfully. He did, sir, again. Wonderful. When you are about to deliver the energy, sir, give air. That way it stays distended. Never suction. Yeah, again. Air and cut. Absolutely. Precise, na? That it's cutting like a butter. Sir, watch the vessel there, sir. That's it. Go slow, sir. There is a vessel on the top there. Yeah, cut there, sir. Cut again there, sir. We didn't cut properly. Yeah.
Make out vertical fiber.
Yeah, sir. But here, that's the reason they say do total myotomy. Yeah, total, sir. Watch the vessels there, sir. Sir, retract, jam the scope, sir. Jam the scope. Flush. No problem. So beginner luck did not help you, sir. I think that one. You want to handle, sir, or you want me to? You want? Yeah. So no need to panic, sir. No, the first thing you want to do is that you already did it, sir. But these are the perforators coming from left gastric artery, so they will become little noisy. So now what you do is that sir, first maintain the vision, sir. At no point you should lose it. Now I want to know before I introduce where it is. So I will understand it is here. Sir. Flush, sister, flush, 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 flush. It is somewhere here. Yeah, yeah. It is. Yeah, which one? Yeah. No, but I don't want to go too up because that is this one. This is your culprit vessel, sir. So I'll keep my cap there. I'll take the quad. Yeah. Yeah. Now, yeah, sister. Yeah. Open, please. Open. Yeah. Yeah, sir. I'm just going to hold it on the muscle side, sir. Open, please. Yeah. Catch, please. Catch. Flush, please. So I am not going to do anything, sir, till I'm sure I've got it. So there, no, yeah. So no bleed happening, sir. Soft coag. Yeah. Don't do it. Did you get it? Open. Oh. Yeah. Yeah, no. The flush is in. I think it's done, sir. Let me check. No. There's something happening with your flush. It's not happening. They take a syringe. I didn't have it. Yeah, probably yes. Need some flushing to understand. It's actually coming out from here. Sorry, you guys got drenched. No, it's not a cap problem. I think something else. Almost stopped, sir. It's almost. Yeah. No. We have to be doubly sure, gastric and. Yeah. Where you want, I have to take this out.
Previous one you had a bleed 7 days after.
Oh my God. Then,
7 days after.
Oh yeah. I think it's oozing from here. Yeah. So there it is. It is oozing on the top, sir. I got it. But that's a mucosal bleed, sir, not a big issue. The bleed is more from the above, which will settle down in a couple of. No problem. Sister, open, sister, please, open. Turn anti-clockwise. Any direction, so that turns little bit. Okay, wait a second. You don't do anything. I'll manage it. I'll manage on my own. Catch. Top coag. Leave. Close. Keep it that way only. 1 second. Yeah, I'll go gently. No, don't open. Close. Keep it close. Because that is mucosal end, sir. I don't want to open this one and catch it. Done. This is mucosal end. Now I don't want to handle it on the mucosal end. Yeah, sir. Open only little. Keep it that way, sister. We will catch it now. I don't want to catch a wide area. Leave. I think it's done. Close. Yeah. Close. Full pressure. Full pressure. That's it. I think it stops. We need that knife a little. I'm done. Santosh, knife. Sir, a little bit of clearance, sir, here. Here, preferably do total, sir. Never do half.
Total is longitudinal should be within.
Myotomy total. In fact, you should see the adventitia beyond. Sir. Sir, keep it like this. So you actually did good, sir. Open. Knife out.
Knife out.
A little bit more control.
Yeah, sir. That takes a little time, sir. But You actually did good, sir. Now you see, sir, I try to open this entire thing. So I can use it just on the top of it, sir, like this. Done. Now we are number. See, there's the basil sitting there, sir. So it's the number 45, 44. Sir, we are at 44, sir. Now that's the vessel there, sir. Which we don't want. We are 44. That's our target, sir. We achieved it. So we are going to examine again. Any bleed? No bleed there, sir. Looks okay. BP 160. It's holding. Yeah. So this was the myotomy you did, sir. These are the longitudinal fibers. Very nice. Coming out, coming out. This is the total you did. Then we are out. Now you go in. It's quite open. I think we have done the job, sir. Oh, leave. So, yeah, done, sir. So we can now safely close it. Clipper, you want me to put the first clip, sir? Yeah.
It's okay.
Yeah, sir. No, this. So this was our incision, sir. So I will check it once. So it's already getting buried inside. No, close. Keep it close, sister. Close. Yeah. I'll just tent it up a little. That way. Yeah, I'll tent it up a little. Yeah. And then I will ask sister to open. Open, sister. Yeah. No, don't rotate. Don't do anything. We are in position. Right? So this is the apex, sir.
Yeah.
So I will just come a little. Yeah. No, don't rotate. No, don't rotate. Yeah. Yeah. Now you can do a trial run, sir. Or close a little and see. Close off, sister. Yeah. Perfect. Close it. Good. Fire. Done. To Olympus and we are done, sir. So you are giving the easy ones to me and difficult to sir. Right? Sir.
It's not touching. It's okay.
No, this is correct, sir. Now you can see that they are approximating. Now you put two more clips, it will job done. One in the middle, one in the proximal end. Sir, you have to push the metal thing out, sir. Metal thing out. Yeah. It got actually probably open. That's the problem with them. They easy to get malfunction. It's gone. It's done. What's your plan? We are going back?
Sir, wants to
Huh?
go for finance.
When? Tomorrow afternoon. Huh? I have to check with the better out. Huh? Huh? I have to check with them. That guy is preparing something. Ah, yeah, I'm there tomorrow only, but yeah, I think you're done. Yeah. Yeah, yeah, please, please. Oh, she's pushing it on one side. No problem. Yeah. Yeah. We'll switch there. So again, same, sir. Go, we keep the scopes, keep the C loop, sir. Stay slightly away. Get the left radical. That's a left lobe. You have a P2 radical there on the top, sir. Now all I do is turn clockwise. Turn clockwise. See, sir. I got the radical here on the top. So that guy I will follow. I will never lose him. So that's the P2 radical, sir. Keep it there. See the one that's coming down is the left hepatic vein. I turn further clockwise. Now this will join with this. See, as I turn clockwise, clockwise. Now if it is drifting to left, push the scope slightly in and there it forms the fissure. Can you see that, sir? Fissure? No, not visible. Yeah, there it is. So ligaments obscure the sound wave movement transiently. So the fisheye turn clockwise, main portal vein. You can see the main portal vein, there is the hilum, sir. So this is the main portal vein, this is that hepatic artery, this is the CBD. You can see the CBD there, and inside the CBD you are seeing some artifacts. There is the aerobia, pneumobilia, and here is the shunt, sir. Yeah. So now I'll trace the portal vein, sir. Take the portal vein, push. Don't lose the portal vein. Follow the portal vein. Follow till it reaches the confluence. There is a confluence. Bring the confluence at 6 o'clock. There it is, sir. See, there gently. Can you see this? Sir? This is the confluence. So I want it just under my probe. So what I'll do is that, sir, this has to stay where we want to actually have the maximum focus. So I want the focus depth to be high. Yeah. Now it will be better, sir. So there you see, sir. Now you see I was trying to follow this guy. Yeah. Now you can see clearly, sir. Yeah. So now, yeah, here we freeze it. We put a comment. So this is your MPV. We were following it up to C. This is your splenic. This is your SMV. Actually, there is one more small vein joining it, sir. Usually that is left gastric epiploic vein, or can be IMV. If the caliber of that vessel is as much as SMV, then it is IMV. If it is narrow, then it's probably left gastroepiploic vein. So once you have this, then this is your HOP. And what is close to this is genu. This is your splenic artery, and this is your BOP. So that's your splenic artery. I'm sorry, here I had a spell missed. That's splenic artery. So that's the composition we want, sir. Yeah, yes, sir. I'll take out the freeze. Yeah, please put the Doppler. Yeah. So now I can show you something else, sir. Now follow this guy. Now I'm saying this is splenic artery, no, sir. Now you see, sir, we will trace it down. Where it is going, I'll show you. So there, you follow that. It will take you to the aorta. So there it is. Yeah. So we started from aorta. This is aorta, sir. This is celiac takeoff. Now keep the celiac in view. Maybe I'll put a color that will make your understanding better. Yeah. There is the, this is your aorta. This is your celiac. Now take the celiac, sir. Now go front. Go front. Yeah. We'll keep the flow here. Flow this side. Yeah. Now take the cursor out. Yeah. Now you are following the celiac, sir. Follow the celiac. We are following it. I am not doing anything. Just keep it at 6 o'clock. There you see, sir. Now the celiac will split. There it is. Yeah. So now you can see, sir. This was the celiac we were following. Celiac artery. Celiac artery gives rise to the one that goes to the right of the screen is the left gastric artery. The one that goes and pairs with the splenic vein is the splenic artery. So this is your MPV, sir. This is your splenic SMV. This is your splenic vein. So celiac artery bifurcates into three branches, sir. Left gastric to the right, splenic artery to the left that pairs with vein, and there's one that goes down, that is your common hepatic artery. So that's the three branches of your this one. So this is the arterial system that you'll see from G junction, sir. If you know what you are looking at, that's it. We will not see anything more than this. Now you see, sir. Yeah. So no confusion now. Now we know when the blue is there, you know it's main portal vein. 1 second. Yeah. So that's the main portal vein. You know the main portal vein is giving rise to splenic, SMV, and what is very close to splenic vein is artery. This is left gastric. The one that diagonally bisects your portal vein is the common hepatic. So we take the Doppler out. So this is what I was saying, sir. Bring the confluence to 6 o'clock. So I will push it further gently, bring it into the 6 o'clock. When I have it right at my position, now I will do slight anti-clockwise. You can see the MPD. Slight anti-clockwise, that's a nice MPD coming from top. So that's the MPD. Now again go back to your, see, that's the MPD.
Yeah.
It's coming down and this is your CBD.
Yeah.
CBD is here, MPD is here. Now I'm back at confluence. Now I will take the splenic vein. Now that is my point of interaction now. Splenic vein, I bring it into the center. Now this is your splenic vein, this is your artery, this is the body of pancreas, and you have a duct here. That's the pancreatic duct. Now keep the vein in center, sir. Keep the vein in center and turn clockwise. Only turn. Don't lose the vein. It will take you to the kidney. There is the left kidney. You can see the kidney there. Now still keep marching till keep the vein in the center, and then finally that will take you to the spleen. That's it, sir. So those are the 9 sections from D1. Bile duct here, yeah, sir. Why not? Yeah. So you wanted bile duct, so go back to here, sir. So that this is your portal vein, sir. Hilum, portal vein. This is your bile duct, sir. Can you see that, sir? That's CBD with the stent in situ. So we measure it. So it's around 14 mm. Yeah, we take out the freeze. Now we want to selectively follow. There is a stone, sir. You have a stone there. So there is a stone here. This is the stone in the CBD. That is casting acoustic shadowing, sir. So this is the acoustic shadowing because of the stone. This one. There is a 11 mm stone there, sir, with a stunt beside it. Now this is proximal CBD, sir. Now you can see the entire stone there, sir. Now I will drive down. You wanted to see only CBD. So now I am driving down. This is mid CBD, sir. Now as soon as pancreas starts, that is now this is the intrapancreatic CBD, this part. This all is pancreas. Now we are heading towards the intrapancreatic CBD. Yeah. Can you see that, sir? There it is. There it is. Now this is pancreas, sir. This entire thing is pancreas. This is MPD. This is CBD. And you can actually, if you are very careful, sir, I can show you the minor also. Here it is. So this is your minor duct. This is your major duct. And they are heading down. So we wanted CBD, no, sir. So this is CBD, sir, all the way from G junction. CBD from G junction. There. So that's D1, huh? Okay. D2. 1 second. I think air is not on. Achha, this one is on. No, it's on. Maybe here we are on the lower side. Yeah. So I will definitely change the video, sir. Go to, yeah. Madam, 5 minutes more. Yeah, you can do. No, sir, we want to go to D1 directly. Yes, sir. D1, sir, yeah. I enter the D1. See, sir, this is what I want. D1, this is the structure. I want to depth of 6 in D1. So nicely you can see the portal vein, sir. Yeah. So this, yeah, sir. No, see, we are at 6 already. So this is MPV, sir. This is our home base station. This is your confluence. This will continue as SMV. This is your splenic vein. This is your HOP. This is HOP, sir. So now once I have this guy, now I will trace. Now I will go proximal, sir. If I want to go proximal, I will do big wheel drop, yeah, anti-clockwise, sir. Anti-clockwise, slow, trying to understand where is the CBD. There is the CBD, sir. Yeah, there is that CBD on the top with the 1, 2. Two are there, sir. Two stones. Here is one stone, here is another stone, probably the another stone proximally. So this is one stone, this is second stone, this is third stone, sir. You have 3 stones there, sir. You can actually go in further, yeah. There you see, sir. So you have 3 pretty much stones sitting there, and yeah, what you can do now is that, yeah. So now, see. Now I am trying to go to the hilum. You can see your stunt is this side. And now I am trying to go towards the hilum. Yeah, no, suction is not on. If you can get some suction. So air is interfering, yeah. Achha, suction fell down. Yeah, now better. Yeah, now you get a better image. So, sir, I was following CBD, sir. This is the portal vein. I traced the portal vein, then I got the CBD. Then, one second. Yeah. There you have it, sir. So, that's the CBD with that multiple stones. Now, we are entering the liver, sir. Liver. So, this is Dr. Aradhya CBD. Yeah. So, keep your eye on the CBD and then turn. I'm doing big wheel away. Now, we are right at the hilum. This entire thing is liver. This is the hilum and portal vein and CBD. And yeah. Now, we'll try to see if we can get hold of your cystic duct. Yeah, you have to just watch it. So, there is a small lymph node. Probably she had a cholangitis sometime. Yeah, here is your cystic duct. See, there, it's going and joining the gallbladder. There is the gallbladder. Gallbladder with multiple stones in it. Can you see that? Yes. So it's a thick gallbladder. Probably you can see the wall is thickened. Right. So that thickening is because she had some cholecystitis or it is still going on. So that's how you examine, and then again you are back to your. This is your CBD. That's the stunt. That's the 3 stones in it. Sir wanted D2, we will go to D2. Sir, for going into D2, we have to again be careful, sir. So, bring the endoscopy image and just like ERCP scope, we will try to enter. Slowly, delicately enter. Yeah, once you are in, sir, now this is the point I was trying to make. Now, I will go. Yeah, depth 4 is good. So now I am trying to adjust that the scope which gets elongated now will slowly start shortening. Once the scope shortens, I am doing only one movement, sir, clockwise. Clockwise, trying to get the big vessels. I want the big vessels. Till the time I don't see them, I will be turning clockwise.
You're already in almost clockwise position. Right?
Yeah, sir. I am just turning slow clockwise, trying to understand where are they. So, if I am able to compress that, that is IVC. So, I will turn slightly clockwise. When I see IVC, I will turn clockwise, I get iota. So, IVC I got, I went to iota. Now, once I get the iota, sir, start watching here. This is our area, 12 to 2. 12 o'clock to 2 is where the head of the pancreas will start. See, there is, where the cursor is there, I will not lose the iota till I get something there. I am just holding gentle withdrawal, sir. Gentle withdrawal. Yeah. I am just slight clockwise and slight turn. There it is, sir. I am just, We should not miss iota. Yeah, the iota stays till you get something there in the pancreas. Yeah, there it is. I am getting the stone there. Can you see the stone coming up exactly where the cursor is there? So once I get that's the CBD. So if you can take out the cursor of the array, I think, yeah, there is the CBD, sir. So once I get the CBD, now I don't want iota. I am just focusing on CBD. I'll turn slightly clockwise. I'll get the MPD also. Did you see the stunt there? There is the stunt. See, there is the stunt there. Yeah. So that's the CBD. That's the CBD with the stone. Yeah. Here. CBD, and that's the filling defect that you have there. A little bit of arrow, pneumobilia is here, sir. And if I turn clockwise, that's the stunt. So once I see the stunt, if I can put some fluid here, this will distend, this duodenum will distend, and I can find an ampulla here. Now once you see the CBD, now this is the time where I turn further clockwise till I get these vessels. So yeah, once I get them, SMB and SMA, that part that is closer to the probe between the vessels is the uncinate. So this is where the uncinate comes. That is the uncinate. We are following. So that's how it is done, sir. Yeah.
Sorry for this.
I don't be sitting there. If he's sitting there, then that fellow is here. So now, yeah, 32, sir, I will make sure I have 32. This is my spine, sir. So I will go for 5 o'clock, sir, and I will give a. This is my spine. I will give a small. So give a. So if he gives a blue flag, then we take. Sir, it will be the submucosa. It's not in the room. Not elevated? No, we need index. Index. You feel this gentle pressure on it. Take it. That's how it is. So what you have to do is that you neglect the down part. That you should not do. Always start to release away, max. Is that? But the one that I showed you, so what was this thing actually? You know, close the knife, and open, close and open. So, see, what I'm telling is that, see, when you are about to start, you know, keep it this way. Inject, go like stop. Once you have stopped the injection, no, pull it back, do big wheel down, go down, go to your left, clear this first, clear the left part. Once you clear that, then engage the right, then small wheel right, then you do this part. You go along this, it's like the curve, not straight. And always aim the muscle, no problem. But small thing will keep coming now and then. Aim the muscle. Take it. Yeah. Air. Yeah. And take it. Again, inject. Now that's the mucosa. So if you move, initial days, inject as much as you want. Again, see, go down. When you have injected, go down. Big wheel away. Yeah, or you do small wheel right, left. Small wheel left. Small wheel left. We'll go to that area on the down. You can withdraw it. See that area. I want you to cover that 9 o'clock. So how you can see? 1 second. I'll show you. Like this. Go big wheel away. So big wheel max away. Max. Ah, now you got it. Now hit it. Now do it. Now. So touch it again. Push the scope. Hit it. Lens wheel. Hit it. Yeah. Now turn right. Turn right. Stay close to the muscle. Yeah, that's the muscle. Now again inject if you want. Inject. Push it slightly. Now big wheel down. Big wheel max down. Max. Go max on the big wheel. Slightly back. Yeah. Now do it. Yeah. Do it. Now do it. Yeah. Fast. Wait. Very good. Yes. Now you are getting good opening. Yeah. Go. Inject. Again, the same orientation. First start with the left. Big wheel max down. Max down on the big wheel. Cover the left, then go to the right. Bring the knife slightly out. No problem. Those are small things. If you are on precise set, nothing will happen. In the beginning, our knife speed is very slow, so precise will send fog only. So you can handle it very well. Do it. So what's happening is that you are not covering much on the left part. It's okay. To the submucosal. Then only you will get that top. Are you at the D junction? I presume. Just check it now. Are you at the D junction? But where did we have the D junction? 41? 38. So you are at D junction. Help us. Yes, sir. Inject. Wait. You have to wait for the now inject. Inject. Do it then. Hit it. No advance. Inject. Sister. Keep injecting. Yeah. Keep the big wheel down, away from you. Wait. Now going. Yeah, you can. But he stays small wheel right. Inject. Very good. Now do it. Yeah. So what's happening is that you are making a cone. You have to make it a cylinder. So you have to widen both edges, left and right. Left and right. You end up making it conical kana. Take it out. Yeah. Yeah, that's fine. No too advanced. Mm-hmm. Needle in. Uh, that's it. Now again inject. Now inject on the top. Needle out. Inject. Needle out.
Clear ಮಾಡಿ sir. You will,
No. That's on the windows. Can I show you something? What I'm saying is that see, here you are at the D junction. Now we play close. How go in? I'm saying clear this. We are not clearing the left side. Inject. Inject. Now what I do see? I keep it there only. I'll clear this left which you are not able to clear. But no. This left if you clear, see how wide it becomes. I just cleared the left. So what I'm saying is that keep it this way. See, go in. The first step is inject. Inject. When she is injecting, I wait. Then retract. Then pull the scope back. Big wheel max down. Go to the left. See, clear the left. And then, small wheel right. See. Yeah, small user here. I finish it up. Sister was complaining there's a small user here. Not done? Not done? The sister not happy? Okay. Yes, sir. Here, sir? No, sir. Still is above. See here. See here. Now, Dr. Anand, probably you're entering the other side. So that's the two vessel sign, sir. So that's the two vessel sign. So that marks the arrival of D junction. So if you see that, you start dissecting to the right of it. So that's how you can spare more obliques. So now the choice is between taking it out with the quack or with the this one, your knife. So if you have decided to, because you feel its diameter bigger than your this one knife, inject. What I do is that I inject, but now. So now I have cleared both ends. Now you have a pretty good chance that you can take it quack. Okay, so it's open now. The quack is now. Quack forces. So because the caliber of the vessel is bigger than the diameter of my shaft, I don't want to take any risk. So we'll do prophylactic. So that is definitely two vessel sign. Sir, probably not. 0.5 to 1 hoga. Sir, that shaft is 0.3. 0.5. Yeah. So now what you will do, Dr. Anand, if you want to do prophylactic coagulation, first we come back a little. We stay here away from the vessel. Bring the coag out slowly. That means we should be away. Or we just pick it. Now stay away. No, stay away. Bring that slowly out. Open it. No. Open it. Adjust it. Adjust this one. Now rotate. So you do this work of Mama. Rotate. Slowly. Jada nahi. So you rotate. Pull back a little. It's moving, not moving. It's not. It won't move. Then the other you have to do. So you go slowly, catch it at the base, near to the muscle. Slowly go in, advance the stroke. Advance, yeah. Open. Catch it near the base. Wait. Don't do anything without boss permission. Catch. Now you are having soft coil. Yeah, you got it. Yeah. Don't wait now. 1, 2, 3, 4, 5. Do it. No, do it again. You half on you do it. No, catch again. No problem. Catch again. Rotate, Amma. Help your boss. Shoot again. Do it again. Do it. Now leave it. Did you get it? I'm not convinced. Something is left behind. Catch it again. Catch it down. Fire. One. Done. No. That's done. Open. Don't physically tear anything. No. If the vessel gets avulsed, then it's difficult to control the blade. Don't suck. Don't touch. Close them, huh? Now wait. Now watch. Flush. Flush. Is it bleeding or have you stopped it? So no bleed, huh? Oh, watch it. Watch it. Done. 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 No, it's fine. The flush is not working. So that was true when this time to go to right.
ಇದೊಂದು ಕೊಡ್ಲಾ ಫ್ರೆಶ್
No, no. Give knife. Give knife. That is in hurry. Give knife. Inside. Yeah, yeah. 2 centimeters from where you saw that 2 measures. ETO is 41. Huh? You started at 34. It's crazy. So you can change it. Yeah, or check the abdomen. If you feel it enough. You can ask them to do a washing depending on their what stage of the procedure they are. So you are happy? Happy? They are happy here. Plus, plus, plus. No, no, it's not working. No, 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 inject, Dr. Aras. I think you can use some. Go in. Yeah, inject. Yeah, bring the knife out, inject. Your boss coming before.
ಔಟ್ ಆಗಿದೆ
Tomorrow. Inject.
ಇಂಜೆಕ್ಟ್ ಆಗ್ತದೆ ಸರ್
Tomorrow. No? So you can. What is your traffic?
ಇಂಜೆಕ್ಟ್
It is down, small wheel right, small wheel right, big wheel down. Wheel down. Big wheel away from.
Needle under-
Away from.
under.
Away. You need
ಹಿಂಗೆ
to go
ಬರ್ಬೇಕು
away. So our playing field is on the right side. That is equal. Okay. Yeah, but you can physically do it with the scope. This is not because. You can take it out, but you need to do that small wheel right. You have to take it at the muscle level. There. Come on, give the knife out to burn. There you take it. Press it. Yeah. One more. Inject. One more.
ಇಂಜೆಕ್ಟ್ ಬೇಕಾ
I think you're done. You're done. Not done. I can go ahead. Okay. Please okay. Yeah, enough. We'll go in. Yeah, take it out. So if you want to take it out, man, withdraw the shaft, turn right. Turn right, take it now. Take it out. Now he's trying to tackle it now, but let's keep the needle out only. This is the reason why we should learn to use the shaft more rather than because then it becomes easy for you as and when to tackle. So you just keep rotating your shaft and then get your gear. I think we are good. You should be able to advance the scope. Now pull the knife in and advance the scope. Advance. Put it in what? Close. Close. Advance. Yep. Yeah. Now needle out, inject, make a bleb, and then advance. Yeah. Out. Yeah. What is it?
ಇಂಜೆಕ್ಟ್ ಮಾಡ್ಬೇಕಾ
Yeah. Yes. Yeah. So keep the knife back, advance the scope. That's the point. Only the white part should be visible, not the blue and yellow. No advance. Yeah, yeah. Yeah. Inject, inject. Yes, very nice. Now you have a very good. Just use your sharp doctor. They don't use anything else. No, but you use it, keep the knife slightly back, slightly ever back. Now inject, cut, inject, cut. Just keep clearing it out.
Inject ಬೇಕಾ?
Yeah. Inject, 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 inject. Now cut, cut. Down, down, down. Big wheel always. Keep the big wheel always down. Now inject, cut. No, no, that is into the muscle. Cut there. Cut there. Blue, blue, blue is red. One more, one more. Now inject, inject. Here. You want me to get to you across? I'll show you one. I'll show you how to do it. No. It's a pre-play of your this one. What I do it? No, no. You are having trouble. See what I do. It's it. What to do? Keep it this much only. Out, out. You're not clearing the left part. Inject. Yeah. Wait. See. See. Now I don't even touch the knife. Pull out. Knife. Pull out. Pull up. Pull. No. No. Not. It's not pull up. Out.
Full out ಆಗಿತ್ತು.
Okay, okay, okay. See, now what I'm doing is that I'm trying to clear the left. See, if I make the left open,
ನಿಮ್ದು ಕೇಸ್ ಮಾಡಿ ಹೋಯ್ತು
yeah. If that is the case, you do it like this also. See, see. You turn the entire thing this way. Even this way you can do. See. So ultimately, that should become an extension of your this one hand. You don't touch the knife. See, I'm not going to touch the knife so often. There's a vessel here. I'll take it out. Done. Knife in and advance. See, when you advance this way, push it to the max. See, you're on the gastric end. You can see that. Now, out, knife out, inject, inject, inject. So this is what I'm saying. Let's see. Now what I do, see, bring it down. See, do this side part, do the left part. See, then go up, then climb up. See, then climb up. So when you're climbing, the knife will go straight, but your muscle is curved. So you have to compensate that by doing small wheel right and turning to your right. See, that's the point. See, our scope will move only up down, whereas the muscle is curved. So in order to compensate that, what you have to do is that when you come into the middle, see, when I come to the middle, either I will do small wheel right or I turn myself right. In that way, I stick to the muscle. I don't go into the mucosa. No. Wait. Inject. Right. Touch. There's a vessel inside. Can you see that? So what I will do is that low precise there. Low precise. Yes, sir. There. So there is the new this one called low precise. Yeah. Do it. Didn't work. No problem. Yeah, no. Yeah, no way. I'll clear this part. Yeah. Now, yeah. Give a flush. Give a what? Flush. We went quite deep, na? 45. Yeah. Enough, na? Enough. Enough. Give me this one. Quiet. Holding it. That's the mucosal. So if we don't want to do anything on the mucosal, we always look where is the injury on the muscle. So now it's out. So what I'll do is that I'll come back. Yeah, it's here. Now, can you see that? There. So I again go in, jam it. Open, please. Open. Yeah. Now I know there is a bleeder. I've changed the scope to bleeder side.
ವರ್ಷ
ಹಿಂಗಲ್ಲ
ಒಂದು ನಿಮಿಷ ಸರ್
Open, please. Open. Can you see that it's pulsatile there? Come on, Patko. Catch it. Catch it. No. Open. Catch. So when I catch, I wait to know whether I have caught the right thing or not.
ಫ್ಲಶಿಂಗ್ ಇಲ್ಲೇ ಮಾಡ್ಬೋದು
Soft coin?
Yes, sir.
ಇಲ್ಲಿಂದ
So since flush is not there, or else I would flush the entire system. So I think they are getting flush.
ಸರ್ ಇಲ್ಲಿಂದ ಮಾಡ್ಬೋದು ಸರ್ ಫ್ಲಶ್ ಬೇಕಾದ್ರೆ ಇಲ್ಲಿಂದ ಮಾಡ್ಬೋದು
ಇಲ್ಲಿಂದ.
ಹಾ ಇಲ್ಲಿ ಮಾಡಿ ಮಾಡಿ ಇಲ್ಲಿಂದ ಮಾಡಿ ಮಾಡಿ
Okay, go ahead. So I'm just checking. There's no
Press
leak
ಮಾಡಿ.
there. So we have caught the culprit. So what I'll do is that I'll gently tent it up closer to me. Enough is enough. Tent it up, and then chop.
ಅಲ್ಲಿ ಹಿಂಗಿರ್ಲಿ ಏರ್ ಆಗುತ್ತಲ್ಲ
Open, open. So once the bleeding is controlled, you don't rush, sir. You close it, close. You take out the tamponade of the cap. Sometimes the pressure of the cap is off, again it starts moving. So you wait. That you don't worry. By the time your myotome is done, it will set. Chalo, knife. So it will bleed for 1 or 2 minutes and then it will get controlled.
ಬಿಡಿ ಬಿಡಿ
So now we will do a flush.
ಫ್ಲಶ್ ಬೇಕಾ ಸರ್ ಇಲ್ಲಿದೆ
No, wait. Flush is little. What I'm doing now is that sir, inject here. Inject here. Inject here.
Inject,
Open.
ಇದು.
No, inject with the knife. Okay. Now we enter the channel to see whether we are good. This is the G junction. We are well up.
ಔಟ್ ತಗೊಂಡು
Right. I'm trying to check for the blood. So can you see that? Blue. Yeah. You are quite clear. Huh? So now what I'll do is that, so this is our G junction mathematically. Just show me. So it's around 40? 40? 40. 40. So it's at 40. So that's what was the original impression. Huh? 42 we wanted to go. So I come back, then search where is my opening. Yeah,
ಅವಾಗ
somewhere
ಹೋಗುತ್ತೆ
here.
ಮೈಟಮಿ
So I enter again. Yep. Once I'm in, so Dr. I have to keep it this way. So this is my tunnel. Huh? This is how I want to go. A knife out. So again, keep everything steady. Watch where is the tunnel.
ಇಂಜೆಕ್ಟ್ ಇಲ್ಲ
This is the mucosal area. Now this is the muscle area. So this is where I want to start. There you go. First end of it. Watch. Did you see that? We are still not getting the lump. It's all circle. So I'll go little bit down. Now we got the planes. There you see. Huh? That's the thick one we have done today. So ask her to keep it like this. Ask her to hold it for you. Then you bring the knife out. Keep it steady. Go below that. And then cut. It's only gently. Again. Is that? Yes, yes.
ಯೂಸ್ ಮಾಡ್ಬೋದು
Yeah, yeah. Great. Now keep the knife sharp, steady, and then take it. Straight it blue. Yeah, blue. Slowly. Allow the current to cut it. You don't tend it up, or it will hit the mucosa. Yeah. Use yellow now. Yellow. It's coagulating. Yellow. Sorry now. Yeah. Done. Come back. See where you are. Go again into no. You are already started doing half down. No, it's here, Dr. Aradhi. Here is your plane. Yeah. That's the plane. Don't push the knife. Huh? Keep the knife steady. Use the shaft. Ask your technician to help you in putting it at 6 o'clock. That way only big wheel you use. Or else you do multiple hesitant cut. Yeah. Better wait, Dr. Aradhi. No, you go. You do. Pull back. Advance, a small wheel left. This is the here. Target there. Ask her to catch it for you. Yeah. Ask her to hold it steady so that you can only do big wheel. Yeah. Do it there. Small wheel left. Yes. Now hit it. You can retract always. See, this is your point. Yes. Try to use the scope and this one. Yeah, big wheel down. Yes, yes, yes. Now you are in the place. Send the knife out quickly. Yeah, hit it. Hit it. Yeah, do it. Do big wheel up. Little bit of yellow. Little bit of yellow. Beware, Max. Yeah, yellow. Use yellow. Very nice. Yeah. One more shot. Yeah. Done. Come back. Check. So we are leaving behind a trail, which we don't know. That's very thick muscle actually. This one. Yeah. Yeah, go. Want me to straighten up and give to you? No, I'll tell you what happened here. See, try to use your scope and cap to your advantage. So what happened here is that little bit we went cross. So I tried to straighten it up and give it back to you. See, I'm using the same blue current, the precise, but you see it is working as a cutting for me because the difference is that when I'm using the precise, my contact with the tissue will be less. So that way it will be cutting currently. Now, because I'm hitting it very close, what I'll do, I change my gear. I'll come from up. See that? So in that way, I'm protecting the top. See, here I feel I'm very close. Huh? Go above and come down. That way, your glucose is always. See, now you were asking, huh? These are the obliques. Can you see that? They're crossing now. So those are the obliques which we don't want to touch. Now it is straight. The back to this. Now it is straight. Now you just use the blue and just do like a pencil shape. Sister, close and open once. That char will go out. Just retract. Open again. Close again. Open. The char will go. Now start. Yeah, we are cutting them. Yes. Keep coming back. Yeah. Yeah. Lens clean. Yeah. Advance. Yeah. Do it. Do it. Use the yellow, your blue. Yeah. Do it. Do it. You are doing good. Now watch your number. Huh? We want to stop at 42. 40. So you are at the G junction. So you need to travel there. You can flush it if you are not very clear about the planes. If you are okay, then keep doing it. You check with the boss. Yes. Good. So it's always good. You will take it clear. Yeah. Yeah. Now do it again. Yeah. Do it. Very nice. So don't stop, Doctor. Just please finish it out because the more you stop, you will attract more quality. Cut, endo cut, endo cut, endo cut. That's close open, close open. The charring is because the speed of the knife determines. You stay in close contact,
Okay,
don't just fog it. Close open, sister. Close open. What is the number of 40, yeah? Wait. Might bleed when we do physical what? Can you bleed? Only the top one is bleeding.
Bleeding.
Yeah, it's losing from the top. Want me to check what? What
Sir,
we do is that,
ಇನ್ನಿದ್ದೀನಿ ನಾನು ಇಡ್ಲು
just here it that.
ಆಯ್ತು
Yeah, out.
Out.
Out. Inject.
Blue.
Inject. Inject. Inject.
Medicine, sir.
Inject. Keep injecting.
Yes, sir. Full time.
Okay. Very good. Great. I will try to tackle it. Inject. So now we are back. Yeah, I just want to show what happened here. Open. So we need to clear this in order to give him more relief.
Only the
Yeah, but it's on the muscle side because of it.
first pick.
Inject.
Inject.
Wait. Give me soft.
For
Santosh.
Yeah.
Give me soft coil.
sir, close.
Low precise.
close ಮಾಡಿ.
Open.
ಹಾ.
Low precise. Huh?
ಹಾ?
Force coil, no.
No, low precise. Put it on precise. Precise only. Change it down. Change the 0.7. Press that. Go down. 0.9 or 0.7. Inject him. Wait.
2.9 ಇದೆ.
0.9. I want 0.9.
ಹೌದು.
Okay? 0.9? 0.9. Yeah. Okay, mark it.
ಹಾ, ಸರ್. Right.
Flush. Wait. I stop. There is something here.
Stop, ಆಯ್ತು.
Stop that. Paka?
Stop.
We'll do the. Sir, one second. Do the regular quiz. Yes, sir.
3.5.
So we are done, sir. We are at the edge of the tunnel. I'm clearing the last 5. Tell, what's the number?
Nothing to be done.
42. Huh? We are good. So I think we can wait. You are saying something? Let's not do this. We'll come out. We'll go to the other end of the tunnel. Yeah. We'll see if there is something here to worry. Not see anything. Sure. Take it. So one final look at the. So we'll try to analyze how we have done the job. Any bleeding. So these are the obliques we are talking. We just left them. And this is the bottom. 42. Okay, sir? Yeah. Fine.
ಸ್ವಲ್ಪ ಹೋಗುತ್ತೆ.
There? Flush up. There is saying there's a whoosh.
ಅದು different ಇದೆ ಮತ್ತೆ ಹೋಲ್ಸರ್ ಇದೆ.
Here.
ಹೋಲ್ಸರ್ ಆಗಿದೆ.
Here. Flush has opened up.
ಹಾಕ್ಬಿಡೋಣ.
Yeah. Where is the whoosh? Flush. Wait.
Wall is there always problem.
ವಾಟರ್.
It's only more of a visual disturbance.
There that total matter is done.
Yeah, done. So I revisit. I don't do anything, sir. I wait. Go out, have a coffee, and come back. And if you want, go in again. Sometimes no need to be over serious. Sometimes just leaving them for some time will bring down everything. I'm just waiting. Nothing is happening. I wait. Yeah, I wait, sir. I wait. Because that's the mucosal end. I don't want to traumatize them. If it cools, then we'll see what. Sir.
ಇಲ್ಲ
To lose this there, we'll wait for a finish.
ಮುಗ್ದಿಲ್ಲ ಮುಗ್ದಿಲ್ಲ ಅವ್ರಿಗೆ ಹೇಳಿದ್ರು ಹೊತ್ತು.
So sometimes you should count this. We leave gap inside. That also happens. So you should be careful.
ಫ್ಲಾಶ್ ಎಲ್ಲ ಹೋಯ್ತಾ ಫ್ಲಾಶ್ ಹೋಯ್ತಾ ನೋಡಿದ್ರೆ ಫ್ಲಾಶ್
You should have that earbuds to clean it. Clean the lens. Lens.
ಕಟ್ಟನೆ ಯೂಸ್ ಮಾಡಿ
ಇದೆ
Okay.
ಕಬಡ್ ಅಲ್ಲಿ ಇದೆಯಾ
Inside. Not exactly, sir. It depends. Sometimes I'm doing it. When you're cutting, the knife should constantly move. If the knife is slow, then it's all boggling. It's sharp. So you have to keep moving the knife. Can't stay at one place.
ಅದು ಶಿವಮೊಗ್ಗಲ್ಲ.
So we go back. Bleeding, no bleeding. No bleeding. Okay, sir. That is right. Which one, sir? That's not right, sir. That's not right.
ಮುಗಿತಾ
Keep No, I was just kidding. You can go and see. Which actually I've already done. There's nothing there. There's no rent there. Clean. Sir,
ನೀವು ಹೋಗ್ತೀರಾ
I'll put only the first clip. I'll only put the first clip. The rest is all yours. Okay, bring it here. Open this.
ಹಾ
Rotate. Then stop. Don't rotate. Bring it down. Yeah. Good. Can you close it for me? Close it. Yeah. Wait. Now I will see. Yeah. Hit it. Close. Done. Perfect.
ಆಗ್ಲೇ ಎಲಿವೇಟ್ ಮಾಡ್ಕೊಂಡ್ರೆ ಈಗಮ್ಮ
What clip to the boss? Give him Olympus is not. No. Don't give him Olympus. Not working. Good. So, Dr. Aradhya, 3 clips, middle and last, and then you're off. I gave you a very nice approximation. You should continue. So, when the first clip is important, if you have a very good first clip, the next clip open max 13, 16. 13, 16, open full. Not open. Now it's open. Yeah. Okay. Advance, big wheel away. Come back a little. Keep the clip out. Pull the clip out. Keep the clip out. And now it's good. It's good. Yes, big wheel away. Try to do a try run. Close it. Big wheel away. Yeah.
ಹೇಳಿಲ್ಲ ನಾವ್ ಹೇಳಿಲ್ಲ ಸುಮ್ಮನೆ ಏನೋ ಗಿರಿ ಮಾಡ್ಬಾರ್ದು Get one. ಗಿರಿ
I think he is hungry. He didn't even realize. It's Suryavanshi. Okay. Get the last clip correctly. Yeah. Right. He still went for a nice one. He made your job easy. Open sister. Always watch the monitor. Don't see anything down. Small wheel right, so it will line up with your clip. Yes. Now just simply advance. Yeah. Small wheel right. Small wheel right. Advance the clip or scope. Advance the scope. If the clip is small wheel right. Yes. Now big wheel away. Big wheel away. Big wheel away. Push the clip little. Nama. Try only. Yeah. Now ask the boss.
ಸರ್ ಒಂಚೂರು ಮುಂದೆ ಹೋಗ್ಬೇಕು ಅನ್ಸುತ್ತೆ.
Open again. Half close. Big wheel down. Yeah.
Open in the below.
Clip it. Ask the boss and clip it. Clip it. Opening it again.
ಸರ್ open
ಇಲ್ಲ ಕರೆಕ್ಟ್ ಇದೆ ಕಣಮ್ಮ.
ಮಾಡ್ಲಾ?
Okay, sir. No, go ahead, na. Little open. Go slightly ahead. Yeah. So withdraw the clip, advance the scope. Now this is perfect. Perfect.
ಮಾಡ್ಲಾ?
Now again, wait.
ಬಾಸ್ ಹೇಳ್ತಾ ಇಲ್ಲ.
Ask the boss. He's the final thought.
ಬೇಡವಾ?
Very nice. No, push it out. Push the clip. Yes.
You are master. ಹೇಳ್ತಿದ್ಯಾ ಮಾಡ್ಲಾ?
Yeah, do it. Yeah, perfect.
ಪಿಕ್ಚರ್ ತಗೊಳ್ಳಿ.
Enough, sir. Enough. Perfect. Nice we got. Chalo. No, sir. Let's not. No, that's good enough, sir. Because it will hold. Thank you. You did good.
ನಾನು ನಿಮಗೆ ಕೇಳ್ತೀನಿ.
Thank you all for attending the conference. Thank you.